me pedía todo lo que me pedía.
Sí, sí, por favor.
Hola, buenas noches.
Mateo, ¿cómo estás? Buenas noches.
Edgar, ¿cómo estás?
Muy bien, muy bien. Buenas noches.
Te escucho, pero no te veo. Buenas noches.
Sí, estoy activando la pantalla.
Perfecto.
¿Cómo estás?
Bien, bien, gracias a Dios. Viniendo del hospital, pero muy bien.
Noche, ¿no? Allá en Argentina.
Y son las 10 de la noche ahora, sí.
Sí.
Ahora mejorando un poco el COVID, gracias a Dios, y liberaron las cirugías vasculares que son no las urgencias, ¿no? Sino las que son de prevención. Así que octubre y noviembre van a estar movidos, gracias a Dios.
Qué bueno, qué bueno.
¿Y cómo andan ustedes?
También ya estamos empezando a meter un poco más de cirugías. A partir de la semana que entra, de hecho. Hasta ahora estábamos operando predominantemente urgencias.
Correcto, correcto. Qué tema, ¿no? Esta pandemia es increíble.
Sí, 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 sí. Nos ha afectado a todos, ¿no?
Sí, mucho, mucho más en el campo vascular, ¿no? La verdad que, por lo menos,
Ustedes van a entrar o están entrando ya al verano, ¿no?
nosotros sí, ya empezamos la primavera, ahora el 21 de septiembre empezamos la primavera, así que empezó a hacer un poquito más calor. Tenemos días fríos todavía, pero está mejorando la temperatura. Y de hecho, las últimas 3 semanas bajaron, por lo menos acá en Buenos Aires y en el Gran Buenos Aires, la cantidad de casos, pero sí empezaron a multiplicarse muy fuerte en todo el interior del país. Y el miedo es que tal vez el interior del país, pese a que haya tenido bastante tiempo, no ha logrado ponerse al día con las camas de terapia. Argentina está muy atrasada en la salud pública y gracias a Dios no nos saturó acá en Buenos Aires y capital. Pero hay algunas provincias del interior que están empezando a estar muy cerca de la parte crítica, estamos mal. La verdad es que no es simple.
Ok. Bueno, pues muchas gracias por atender el web seminar, Mateo.
No, gracias a vos por la invitación, es un honor para mí estar hoy, en serio.
Sí. Vamos ahorita en cuanto activen el video para empezar. Me voy a desconectar un momento. No.
Hola a todos, vamos a dar inicio en un par de minutos.
Hola, hola.
Un saludo, Chucho, ¿cómo estás a todos? Buenas noches.
Hola, Paco, ¿qué tal? Muy buenas noches. Vamos a dar un minuto, ¿eh? Tenemos un problema técnico, pero ya estamos en un minuto.
Claro.
Ok, Chucho, ya está. ¿Me escuchas?
Sí, le escuchamos bien.
Ok, pues si quieres, empezamos.
¿Sí?
Voy a...
¿Gusta compartir su pantalla, doctor?
Ok, déjame nada más ver. Doctor Kawashima, can we start? Okay, let me make the introduction, please. Wait a minute. Okay, voy a empezar, Chucho.
Adelante. Ya lo vemos bien.
Ok.
Si gusta compartir su pantalla, ya iniciar cuando guste.
Okay, good evening for everybody. All of you are welcome to this webinar series of the National Institute of Neurology and Neurosurgery, Manuel Velasco Suarez in Mexico City. I want to introduce first my collaborators. The Institute, as you know, is the main institution in Mexico for the treatment of neurological disease. And we have many departments inside of the neurosurgery division, like the cerebrovascular surgery, the endoscopic skull-based surgery, the open skull-based surgery, spine surgery, functional neurosurgery, tumor surgery, epilepsy surgery, and radiosurgery. You can access all the information to our institution through this address at the bottom of this slide. And this will introduce you into the Institute as well as all the activities that are under development in our institution. In this time, we will present our first webinar that is entitled Masters in Cerebrovascular Surgery. For this webinar is sponsored by the Institute and also by the Mexican Society of Neurological Surgery, and this account for credits for the certification of Mexican neurosurgeons. I want to introduce myself. I'm Edgar Natal, the director of the Division of Neurosurgery at the Institute. And in this time, I have the collaboration of Dr. Jesus Martinez. He's neurosurgeon and is the manager of the digital platform. So he's responsible of the good functioning of this event. After then, we have a Dr. Oscar Gutierrez Avila, a neurosurgeon, is acting like a co-director, and he is a present fellow of the cerebrovascular surgery program. Dr. Leo Tobar is also neurosurgeon, is acting like co-director and is fellow of the cerebrovascular surgery program. I want to introduce our speakers in this occasion. At first, I want to introduce Dr. Tatsuya Ishikawa. He is the president of the Research Institute for Brain and Blood Vessels in Akita, now also known as Akita Cerebrospinal and Cardiovascular Center. He is a very renowned neurosurgeon. He has a lot of papers published in the international literature, and he will talk us about the ideal closure line for the treatment of complex MCA aneurysms. After, I want to introduce Dr. Akitsugu Kawashima. He has been our host in the past at the National Institute, where he has been underwent so many operations with Dr. Henry Niemi. and he is the director of the Department of Neurosurgery at the Neurological Institute, Tokyo Women Medical University, and Yachibo Medical Center. He will talk about bypass surgery, and he will show his very detailed technique to perform many types of bypass. Then we have Dr. Junta Moroy. Dr. Junta Moroy is the head of the Division of Neurosurgery at the Research Institute for Brain and Blood Vessels. The Research Institute for Brain and Blood Vessels has been the school of many neurosurgeons, including me and many other Mexican neurosurgeons. So we are very grateful for this institution, and we also it's a very good opportunity to hear about your experience. There are a lot of panelists, invited panelists. So we will have with us Dr. Mateo Bacanelli, that is right here now, Dr. Rogelio Revuelta, Dr. Mauro Segura, Dr. Francisco Lopez, Dr. Mauricio Longo from Guatemala, and Dr. Rabindranath Garcia. So let's start, and I will ask Dr. Akitsugu Kawashima to unmute yourself and share your screen.
Can you see my presentation?
Yeah, we can see your presentation, Professor.
Is it okay? Okay. Thank you, Professor Natar. It's a great honor for me to be invited to this webinar, Master in Cerebrovascular Neurosurgery. I talk about the variation of bypasses divided into chronic ischemia and acute flow replacement. Is it okay? Thank you, Professor. I visited Mexico to participate in live surgery in 2018. I met Professor Natal firstly and deepened friendship at this time. Surgeries and experiences in Mexico were very exciting and impressed on me. People in Mexico are very kind and friendly. I stayed with very glad and enjoyed in Mexico. And I also enjoy the outside of OR. I like Mexican food and love medical. Next year, senior resident Oscar visited in our institute from Mexico. He was recommended by Professor Natal, and he adapted himself to our institute and colleagues. He stayed in my hospital from early morning to late every day. Today, I'll talk about indication divided to chronic ischemia and acute flow replacement, next variation of procedures with video, and finally, unsolved problems from my experiences. So, the first SPM-shaped bypass was performed in 1967 by Professor Yasajiro. This technique was adapted not only to ischemia, but also to complex aneurysm. Over 50 years, bypass techniques was developed and polished. There are my cases. 40% myelin disease and 40% also endoscopic disease and 16% for acute flow replacement, including the complex aneurysm. And posterior fossa bypass is 82 cases, and high flow bypass 73 cases, including this acute flow replacement and ischemic patient. The table demonstrates variation of bypasses. This white color fonts are basically for chronic ischemic patient. And these green ones are for acute flow replacement, and orange colors are in both for both. Indication of ECIC bypass is divided to chronic ischemia and acute flow replacement for aneurysms. I'll explain future of bypasses respectively. Characteristics of the chronic ischemia is in a long-term chronic ischemic condition. It means patients have time to develop blood supply from the graft. On the other hand, bypass for aneurysm is for intraoperative acute flow interruption. It means sufficient blood supply is needed immediately. It's quite a difference between two pathologies. So surgical indication for chronic ischemia is basically main trunk occlusive condition, symptomatic, and with hypoperfusion of CVF. Low flow bypass is selected because patients have time to develop the blood supply, and there is some risks of hyperperfusion syndrome and long-term chronic ischemic condition. And by the way, COST trial is a randomized controlled study whether ECIC bypass prevent ischemic stroke in a hemodynamic ischemia. This study concluded ECIC bypass did not reduce the risk of recurrence ipsilateral ischemic stroke at 2 years. However, there are many problems. Main reason for the result is the impact of postoperative ischemic stroke rate. It's 14%, very high rate. It's also that 93 cases were operated on by 30 different surgeons at different centers within 80 years. This is very terrible condition. There are many reports of effectiveness of ECIC bypass for ischemic myocardial disease. And recently, effectiveness of ECIC bypass for hemorrhagic myocardial disease is also proved. It can reduce the rebleeding risk and improve the patient prognosis for hemorrhagic myocardial disease. So let's move on the acute flow replacement. INNS is placing the ECIC bypass for acute flow interruption with temporary or permanent occlusion, mainly in cases of complex aneurysm. Acute interruption may cause ischemic complications. Sufficient blood supply is needed immediately in such cases. High flow bypass is selected for reconstruction of the ICA or MCA in many cases. In this meaning, flow augmentation is extremely different from chronic ischemic cases. I show you the case of giant MCA aneurysm. We use ECIC bypass not only for replacement of the ICA, but also for long-time temporary occlusion to protect the ischemia. After opening the Sylvian fissure widely, we made the STA M2 bypass for insurance of avoiding ischemia according to long-term temporary occlusion of the M1. After that, after making the bypass, we place the temporary clip at the M1, temporary clip, and dissecting the aneurysm and the clip. The patient's postoperative course of the patient is very nice. This case is not interruption, permanent interruption of the main trunk, but the long-time temporary occlusion of the M1. Or in this meaning, the bypass is for the insurance of avoiding ischemic condition. So next, I show you the variation with video.
Yeah, could I order something to pick up?
This is our standard bypass procedure for
786
chronic ischemic.
305
We always
560
perform the STA double bypass for
1654.
ischemic patient. The skin incision
Combination
is
beef and
on the
broccoli
parietal branch of the
with
STA
pork
like
fried
this.
rice,
And
egg
the skin
roll,
incision until all
and
free.
Sprite, and
And
wonton
The
soup.
frontal branch of the STA was dissected
Okay,
from the garlial side
that's it.
and opening the making the
I'm
craniotomy
sorry.
5 centimeter in diameters.
Yeah, I'll pick up right now.
So after preparing the bypass, we selected the artery. Usually, we selected the supra and the infrasylvian fissure respectively. We introduced silicone rubber stent while creating the anastomosis. It's very helpful for such a small fragile vessels, especially for a pediatric minor patient. The stent provides good visualization of the orifice of the recipient artery and expands immobilize the collapse orifice after the arteriotomy and help to avoid soiling the contralateral wall. The silicone rubber stent is removed off before tying the placing sutures. I'll show you the video. The patient is a 5 years old girl with Moebius disease, right side. Now, I dissect the parietal branch of the STA, and you can see that graft is very small in this case. After the arteriotomy, we put in the silicone rubber stent like this. I use the tensile monofilament. The wall of the recipient artery is very fragile. Before tying the old sutures, we put off the silicone stent. After making the first bypass, I add the one more bypass. For the young pediatric patient, I added the indirect revascularization. So this is STA, ACA, and MCA bypasses. I provided this new technique for minor disease in 2010. Indication is minor disease with strong hyperperfusion in the ACA territory and ischemic symptoms in the lower extremities. We press the craniotomy 2 places at the ACA territory and the MCA territory, and dissect the long STA, long dissection of the STA, more than 10 centimeter. And this is a key point, that the graft was passed under the under the dura. So I make the it's good. The graft course as a natural is a very important. This procedure, of course, make a lot of times, and needs 2 craniotomies, but effectiveness is very good. Extensive blood supply in the whole frontal lobe in many cases. So next is the hypo bypass. The aim of hypo bypass is the replacement of the ICA or other large vessels to supply high amount of blood flow. In my case, skin incision is like this. We usually use the saphenous vein graft and the neck open, and the craniotomy was made not so closely to the terion, different from the clipping. We tunneled from the neck to the craniotomy edge below the zygomatic arch. We pass the Gore-Tex artificial graft, this one, in the tunnel between this, and then press the vein graft inside the Gore-Tex artificial graft. The graft is pressed under the zygomatic edge and the mandibular. Like this. The artificial Gore-Tex graft protected this saphenous vein graft. We add the STA bypass, this one, for insurance of occlusion of the hypo bypass graft. I show you the surgical video. After the opening the bypass, opening the sugar fissure, firstly, I make the STA M2 bypass. Like this for insurance. Then we do the hypo bypass. Now we suture the saphenous vein graft and the M2 using the 9-0 monofilament continuously fashion, running suture fashion. And then move the neck. The origin of the we suture the other side of the graft to the origin of the ECA, like this. Don't need the large craniotomy. So this is the IC bypass for prevent the ischemia in the posterior circulation. This case was progressive basilar occlusion, and symptoms repeated severe dizziness, syncope attack, and disturbance were also progressive. STA bypass is indicated for cases of insufficiently supply of the basilar artery. This procedure is very effective. In such patients, the symptoms were stopped after operation. But the decision of indication is a little bit complicated. To evaluate hemodynamic insufficiency in the posterior fossa is still difficult. So we should carefully decide the indication in such cases. I will show you the basic procedure of our STM bypass via subtemporal approach. The anterior segment of the skin incision is marked over the parietal branch of the STA, like this. After decision, approximately 8 or 9 centimeters of the STA graft. And so the incision is above the ear lobe. Obtaining a 5 or 6 centimeter bone flap. Additionally, drilling is performed at the temporal base to flap the temporal base. However, extensive mastoidectomy is not necessary. The temporal lobe is then gently retracted to expose the ambient cistern, and then it's open to release the CSF with reserving the fossa nerve. The tent was widely cut to obtain the better surgical field. It's very important to keep the good surgical field for the anastomosis. For set up the starting the anastomosis, keep clean in the operative field. Anastomosis is complete using the either 10-0 filament or the 9-0 with running sutures. So this is a case of vaginal bifurcation large annulus, showing with wide neck, posterior direction, high position located in the interpeduncular cistern like this. Modular size of the left pecum and the right pecum could not be shown. Our strategy was flow reduction of the annulus, interrupt the upper vaginal with right STA bypass, subtemporal approach. After widely open the tent, now I check the, I look the annulus, but the very limited. So now I dissect below the third nerve. This is the basilar trunk, or the interrupts the basilar artery. And this is the SCA. Now I anastomosis SCA to the SCA. The surgical field is below the tent. After making the bypass, I interrupt the basilar artery just below the SCA. I checked the blood flow by ICG and Doppler. Five months after operation, the thrombosis of the aneurysm were not complete, but more than 1 year and a half, the aneurysm has disappeared. This procedure is published in neurosurgery. This is for surgical treatment of the P2 aneurysm. Previously, reconstruction of the P3 was reported as OA PCA via occipital interhemispheric fissure with divided craniotomy from the manipulator of the aneurysm. We reported trapping of the P2 aneurysm and reconstruction of the P3 can achieve via same subtemporal approach. This is a SCA bypass for SCA large aneurysm. This is also via subtemporal approach. The clip the aneurysm with SCA bypass. I'll show you reconstruction of the pica. This case is thrombosis basilar aneurysm involved. As usual, this caudal loop, this one, of the pica was the best region of the as a recipient artery on the medulla. Because operative field can be made widely and shallow. This is a caudal loop of the pica. The surgical field is not deep. On the other hand, in this case, the caudal loop here is very small size. So we selected the lateral segment of the pica, this one, as a recipient artery. But in this case, not caudal loop, but the lateral segment of the pica, the surgical field is relatively narrow. And very near the lower clavicular nerve and the 7th and 8th nerve. So in this case, the surgical field is very narrow, so I select the running suture at the anastomosis using the 9-0. And very near the lower clavicular nerve and the 7th and 8th nerve. Yes. A little bit different from this caudal loop. This lateral segment is narrow and deep. So next is I show you the unsolved problems. In almost all cases, bypass is very effective for ischemic disease, including liver disease. Overall, the complication rate in ischemic cases are very low, especially compared to cost study. Ischemic complications like this. But there are some surgical complications. This is a hyperperfusion syndrome. It's one of the typical complications in cases of liver disease. There are some ischemic complications like this. This case is ischemic stroke on the contralateral side. This is a hyperperfusion syndrome. And sorry, this is the bypass for the complicated aneurysms. But these cases, the bypass is good, but this dissection of the aneurysm or the around the structure, the complication of the lower cranial rocks are very severe and have to be careful. Additionally, in some cases of infant mammary disease, progression of the ischemia is very fast and severe. So reconstruction surgery, including bypass, can solve this category of cases. So, conclusion. Treatment options have expanded using the proper bypasses for chronic ischemia and complicated aneurysms. Unsolved problems are still remained. A vascular neurosurgeon must maintain a proficiency of surgical skills. Thank you very much.
Thank you very much, Dr. Kawashima, for your excellent presentation about bypass. I would like to open some questions by part of panelists. Please, if somebody of you want to make some remark or question to Dr. Kawashima. Mateo, want to make some comment? Maybe your microphone is closed.
Hello. Okay. Can you hear me?
Yes.
First of all, I want to congratulate for the conference. It has been incredibly very, very good surgery and techniques. My question is about preoperative operation, preparation of the patient. How do you handle the patient before surgery? Did you use aspirin when you begin the doses?
Yes. All of our cases, I take the aspirin 100 milligram before operation. I stop the aspirin the day of the operation, and 5 days after operation, restart the aspirin.
Okay.
Dr. Kawashima, I would like to ask some question about the also medication during bypass. In the case of high flow bypasses, do you use only aspirin or you use heparin?
Just aspirin, not heparin.
Okay, and you don't,
Yes.
you don't have any trouble of thrombosis using only aspirin?
Yes. Fortunately, I have no trouble on the extradural aneurysm. But I have a few cases of thrombotic complication in the intradural aneurysm. I mean that not in the graft, but the thrombotic formation in the aneurysm with some perforators.
Okay, any other question from the panelists?
I would like to make a question.
Yeah.
Do you use papaverine or something to soak the cotton eyes to moisture the graft to prevent vasospasm of the graft?
Yes. I always use papaverine to prevent the mechanism spasm of the graft.
Okay, Dr. Rabin, you have performed some bypasses. Have you any question or some comment about it?
Thank you, Professor. Yes, I just one question. How useful or how easy is to take our occipital artery to make a bypass to MCA? It is possible?
Yes. In some cases, for example, after the initial reconstruction patient in Moyamoya disease, after reconstruction surgery using the STA, some ischemic symptom was continued. In such cases, I sometimes use the OA MCA bypass.
Thank you.
There is any question for Dr. Kawashima?
I have a question.
Yes. Go ahead.
Hi, good night for all. Dr. Kawashima, how long do you keep aspirin in the treatment? It's only one day, or how long your time?
Over 1 week before operation. Over 1 week, and after operation, I continue to at least 1 year.
Okay.
Yes.
Thank you.
Thank you.
Okay, Dr. Kawashima, we appreciate very much your participation in this web seminar, and
Thank you.
we expect to see each other in the near future. Thank you very much. Good evening here, good morning there.
Professor Natal, sorry, I have to go OR after after this. So
yes.
yeah.
Yes.
I have to say goodbye.
Okay. Thank you very much. Bye.
Thank you very much.
Okay. In the next, we are going to present Dr. Junta Moroi. He will speak about the vascular compression syndromes. But at first, he will make some introduction about the Akita Research Institute. So please, Dr. Moroi, go ahead with your screen. Thank you very much for your participation.
Okay. Can you hear me?
Yes.
Okay. I'll start my presentation. Can you hear? Can you see my slide?
Yes.
Okay. Thanks, Dr. Edgar Natar, for inviting me and giving me an opportunity to present my surgery in this webinar. First of all, I'd like to introduce my hometown, Akita, and my hospital, Akita Noken. Akita is here. Akita is 1 hour flight away from Tokyo and countryside. Population is about 1 million, but getting smaller. And aged area, 65 years old or older, occupied 38% in population. I think Akita is oldest area in the world. Our hospital is called Research Institute for Brain and Blood Vessels, Akita. It was established 1968. In Japanese, people call this hospital as Akita Noken. Akita Noken have many good neurosurgeons in its history. He is Dr. Zentaro Ito. He is one of pioneers of Japanese microneurosurgery. He published textbook for microsurgery of cerebral aneurysm in 1985. Another great neurosurgeon is Dr. Nobuyuki Yasui. He is master not only for us, but also for Dr. Edgar Natal and many Mexican neurosurgeons. He developed anterior interhemispheric approach to basal interhemispheric approach. This approach is our legacy in ACOM aneurysm clipping. This case is 65 years old male patient with a ruptured ACOM aneurysm. Skin incision is shown as red line in this figure. And two-piece craniotomy is made like this. This lower piece of craniotomy provides no breathing vein space. Via this space, we can operate ACOM aneurysm less invasively to brain. Additional lower craniotomy provides no bridging vein route to ACOM. Dissection technique is performed in traditional way in a hospital. Here is aneurysm. You can see. Dissection aneurysm is easier in this approach than Kellner approach. Clipping space is enough to handle clip, and clipping is very easy. Easy clipping is equal to safety clipping. Last year, our hospital got new building, including brand new operation room and changed the name to Akita's Cerebrospinal and Cardiovascular Center. Young Mexican neurosurgeon, Dr. Oscar Gutierrez Avila, worked in this hospital in 5 months. His performance was excellent and published one technical note in World Neurosurgery. I hope another neurosurgeon like him run in this hospital in the future. Okay, my presentation title is Vascular Decompression for Posterior fossa. I will show you our MVD technique for microsurgery, for trigeminal neuralgia and hemifacial spasm. Park range position at this picture. And vertex slightly down and chin down to make mastoid process in the highest position. And shoulder is pulled downward. Craniotomy is one key step in this surgery. Using 3D CT image, surgical planning is useful. This 3D CT image shows transverse sinus and sigmoid sinus, and orange color shows mastoid air cells. First, decide key burr hole at the knee portion of transverse sigmoid sinus. Second, design craniotomy line to see posterior edge of sigmoid sinus for facial spasm, transverse sigmoid sinus for trigeminal neuralgia. After craniotomy, design skin incision. This patient is 28 years old, female with left hemifacial spasm. Skin incision was designed at red line and turn skin flap, preserving fascia surface. And take free fascia piece for dural plasty. So the process here, and take fascia here. And sorry, my mouse don't work. So just a moment, please. Okay. Undermine this area, take fascia piece 3 centimeter in diameter. It is uprich. Then fascia incision like this. Cut only fascia, not muscle, and turn fascia to forward and upward this side, and dissect all muscles from bone. Cut emissary vein and reduct muscles downward. And burr hole made as designed position and cut bone and sigmoid sinus side drilling and caisson to make craniotomy line. Bleeding from emissary vein stopped by gel foam. And craniotomy done. Semicircular dural incision made and turn dural flap to sigmoid sinus side. Then I'll talk about trigeminal neuralgia. 2 points I will talk. Trans-horizontal fissure approach and jack-up technique for vessel fixation. Horizontal fissure is lined at D in this picture. This approach opens proximal side of this fissure. First, open horizontal fissure, and then open superior limb of cerebropontine fissure. At this fissure, there are some venous branches of the dorsal vein. Dissect these veins from cerebellum, we can reach breadth of trigeminal nerve. This patient is right trigeminal neuralgia. We can find horizontal fissure just rostral of brocus and open. And then dissect whole arachnoid membrane from veins. Cut and remove all arachnoid. This is fine. And this technique, this procedure is fine technique. Removing arachnoid make those veins mobilize from the cerebellum. Sometimes these small veins start to open the fissure, but I don't coagulate those veins. Don't sacrifice. Those veins often be dissected, and then superior limb of cerebral content fissure is completely opened and red here and SCA opening vessel here. This approach is similar to trans-cerulean approach for IC aneurysm surgery. Frontal lobe retraction and temporal lobe here, and remove the arachnoid from veins. We can see aneurysm. In this approach, open horizontal fissure and dissect the arachnoid, and then we can see target here. Almost same structure, but young neurosurgeon learn this distal trans-cerulean approach first until they master bloodless dissection in this approach, and then learn this transhorizontal fissure approach, because operation field and veins are smaller, and injury of some of vein may cause severe morbidity. This slide shows prosthesis used in NVD in Japan. Namely, Teflon is used for non-absorbable material, and fibrin glue is popular for absorbable material. I think both material is used in combination. I use polyurethane sponge like this. I put slit in sponge like this. It's about 5 millimeter in size. I crush sponge and hold by bipolar to bring to opening vessel. This technique prevents a injury in front of legs. This case is right trigeminal neuralgia, already reached to legs, and SCA was removed, and crushed sponge released on the surface of pons and set sponge like this. That's it. I call this technique a jack-up technique. This sponge jack-up SCA to tentorium, and this slit hold SCA. It's almost same car jack-up. And this style SCA should be jacked up to tentorium for decompression. This picture is the same case. A tentorium here and infratentorial surface of cerebellum here. And distal side of SCA is jacked up by sponge from cerebellum. This case is right trigeminal neuralgia. Opening vessel is SCA. Already open horizontal fissure, we can see reds and offending SCA. Here, there's SCA. SCA is dissected from reds and moved to tentorium. Then crushed sponge is brought to pontine surface and jacked up SCA to tentorium. That's it. This is distal side of SCA. Distal SCA is put to supracerebellar space and jacked up. This is final view of this operation. You can see SCA running away from reds. Another case. This case is left trigeminal neuralgia. Offending vessel is SCA. This case has developed petrosal vein. Opening horizontal fissure and dissect all arachnoid from veins, and we can see reds and SCA. Dissect SCA and move to tentorium. Then brush the sponge. It's easy to handle between those veins, put pontine surface to jack up SCA to tentorium. This technique makes reds free completely. Next topic is facial spasm. I emphasize to observe all of the facial nerve. This is famous paper about vascular compression point in facial spasm. Before this paper, many neurosurgeons focused to so-called reds here and remove vessels from reds. At this picture, we can see facial nerve go down the surface of lower pons. This part called attached segment. After this paper, checking this attached segment is a routine step in M3D of facial spasm. To observe attached segment constantly, we must dissect arachnoid widely to see medullary sulcus. Here. In this case is left facial spasm patient. He is very young, so he has tight posterior fossa. Offending vessel is ICA. vertex this side and hook this side. Craniotomy is very important in younger case. Posterior edge of sigmoid sinus should be exposed. And semicircular dural incision and turn wrap. Open cerebral medullary system withdraws CSF. Dissect arachnoid around the lower cranial nerve and acoustic and facial nerve complex. Arachnoid around pica. This is when vessel should be dissected. That make it mobilize. Again, go back to lower cranial nerve to dissect, to confirm medulla. This is the important point. But we can see medullary sulcus here and attached segment here. In this case, offending vessels, ICA compressed reds, no attached segment. Here, reds. I dissected ICA from reds and mobilized. Usually, some small branches to pons. To preserve these branches, sponge was used to jack ICA up from onto the surface. Another sponge is placed to jack distal ICA up from cerebellum. This artery is not offending vessels. Checking sponge fixation by water irrigation. This is final view of this surgery. Next case with right interfacial spasm. When the vessel is pica. Already approach to attached segment here. We can see indentation on the surface of attached segment. Sponge is placed under the offending pica and jacked up. Attached segment is free from offending vessel. Next case, this is last case. Right hemifacial spasm patient. Offending vessel is ICA. Again, I emphasize dissection of arachnoid of lower cranial nerve is most important in this approach. Then observe attached segment. We can see indentation. In this case, also have many small branches from vessels. But to preserve those vessels, sponge was placed between attached segment and vessels. So this is interposition. Okay, closure is performed like this using fascia flap. The dura is closed water tightly, and rest of fascia placed on opened mastered air cell and put artificial glue and fixed with dura flap. And again, artificial glue and granuloplasty and close fascia like this. We can close water tightly so that prevent CSA leakage and close skin. This is final view of this operation. And last slide, I'll show my surgical results. My case is not so many. Excellent and good, occupied 91% in trigeminal neuralgia and 97% in facial spasm. Summary. I showed our surgical procedure in MPD. Understanding surgical anatomy and making bloodless field, and in addition, preserving all vessels are most important for safe and effective decompression surgery. Thank you for your attention.
Thank you very much, Dr. Moroi, for your wonderful presentation. We will start a short round of questions for you if you are in agreement. There is one question from the by Dr. Harshad Parekh that is asking you, during any facial spasm, decompress, you don't handle the seventh nerve. Why you need to dissect around lower cranial nerves is the question as was made. Did you understand?
I think so. Its question is asking why I dissect the lower cranial nerve.
Yeah, that's right. Yeah, that's correct.
Okay, so I emphasize attached segment that is lower pons surface of lower pons to observe that portion. Lower cranial nerve dissection is necessary to safe operation view.
Okay. Dr. Mauro Segura, do you want to make some comments? You have a lot of experience in microvascular decompression.
Thank you. Can you hear me, Professor Nata?
Yeah, I hear you.
Yes, I hear you too.
Dr. Moroi, I'd like to see your beautiful presentation. I'm very happy to see the new Akinoken. I was there at your hospital maybe 20 years ago with Professor Yasui, so I'm very happy to see the new hospital. In this case, I'm not agree exactly with the so huge approach. For me, 18 millimeters, 20 millimeters is enough to reach the pontocerebellum angle. But maybe I'm according to you, the young surgeon have to train and little by little to improve the size. It's not a matter of the size, it's a matter of the surgical technique. So And another point I'm very interested that how risky could be the transhemispheric fissure approach. I'm not sure, but I'm very interested to learn about your technique. So for me, it's very interesting, Professor Moroy, and thank you, Dr. Nata, for this interesting presentation.
Thank you. Then I think a trans-horizontal fissure approach is not always needed. But to keep skill, maintain, I try every case to open horizontal fissure.
Yeah, I hear that it could be same that at the beginning for the aneurysm approach. So I will try. Thank you very much.
Thank you.
Is there any other question?
Well, someone else, maybe in Japan, today is October 7th.
7th, yes,
so
right.
It is an international commemorative day for the trigeminal neuralgia in the Occidental world. Maybe the same in Japan. So we are celebrating with this commemorative.
Okay. Dr. Moroy, there is one question by Dr. Carlos Arellanes. Carlos Arellanes was also in Akita some years ago, and he asked you if you make some monitoring during surgery.
ABR is necessary. ABR.
Okay.
Auditory response. Brainstem, auditory brainstem response.
Okay.
That's it.
Okay.
Monitoring.
Yeah, two other questions by the audience. Dr. Alberto Villegas asked you if you do you think of sling techniques in microvascular decompression, especially in cases of basilar dolichoectasia?
It's very difficult. So dolichoectasia case, we put a lot of prosthesis use, just interposition. But so moving those arteries is very dangerous. So interposition is better, I think.
Okay, another question by Dr. Harshad Parekh is if you have any incidents of post-op 7 nerve paresis after decompression.
My experience, no first surgery, no facial nerve palsy, but delayed facial nerve palsy occurred in 3 cases. But they all recovered by steroid and vitamin 12.
Okay, thank you. Dr. Arturo Ayala from Mexico is also a skull-based neurosurgeon and vascular neurosurgeon. He asked you how many reinterventions you have in your cases.
Pardon?
Reintervention. Reoperation.
Reoperation.
Yeah.
Reoperation maybe 3% or 5% around that. So I cannot answer exact number, that percentage, but maybe 3 to 5%.
Okay. I want to make you one question about the material you use for the decompression, the polyurethane. Mm-hmm. This material is very similar to the material that is in the scrub brushes.
Mm-hmm. Yeah. Right.
So is different from this, or is some different procedure to prepare the material?
This is same material, and I open brush and cut sponge and put under the pencil.
Okay, very interesting.
Off level.
Yeah, very interesting, because we use Teflon, but this is an alternative material. And you don't have any reaction by?
No reaction.
No reaction.
So immuno reaction, also allergic reaction to me. So no allergic reaction.
Okay. There is another comment by the panelists. Please go ahead. Mateo, do you want to make some comment?
Okay. No, but it's very interesting, the dissection, because generally I use to go from the supracerebellar infratentorial way, and not for the petrosal, just directly to the trigeminal nerve. I understand that the dissection of the fissure is in order to more free the vein and just come at the side to the vein, arriving to the place of compression. But it's very interesting, because I generally go from upstairs, not from the petrosal face. But very, very interesting. I didn't think in open the transverse fissure. I'm gonna take it in account the next time. Really interesting.
Thank you.
Yes, another last question maybe is made by Juan Jose Ramirez from Mexico. He asked you if do you have experience for microvascular decompression for vertigo?
No, not yet. Not yet. But no indication, I think. So very difficult to judge MVD is effective or not. So I don't perform MVD for vertigo.
Okay. Any other question or comment, please? Well, the last question, Dr. Arturo Ayala, I think it's an interesting question, because sometimes we, in some difficult cases, even with reoperation, he asked you about the inner trigeminal neurolysis.
I know that technique, but I didn't perform yet.
Okay. Well, thank you very much, Dr. Moroi, for your presentation. Very nice presentation, very beautiful surgeries. Thank you very much. Right. So we will present next Dr. Tatsuya Ishikawa. Dr. Ishikawa is, as I told you, is the president of the Akita Noken Center, and he has developed a very interesting technique for clipping complex MCA aneurysms. So I will ask Dr. Ishikawa to share his screen, please.
It looks everything all right?
Yes.
Okay?
Yes, okay. It's okay.
Okay, let me start my presentation. Buenos noches for every audience, and good morning for Japanese audience. My talks, thank you, Dr. Natar, to give me an opportunity to talk in front of the audience all over the world, and it is my great pleasure. Today, I'm talking about a very simple thing. So it's a theory of surgical clipping of cerebral aneurysm, titled as a concept of closure line is helpful for achieving completely net clipping for middle cerebral aneurysm. I proposed the concept more than 10 years ago, and I have become and it have become very familiar in Japan, but I have a few chance to introduce to the foreign neurosurgeon. I have already published a paper in 2009. So please see the paper if you want to know about the detail. So first of all, we recognize that neck creeping has been a robust neurosurgical technique for treatment of cerebral aneurysm for recent 50 years. Now it is gradually being replaced by endovascular coiling. As David C.A. have mentioned, a subset of residual aneurysm may result in enlargement or rupture, although the risk of recurrence is much less than coiling. In our institute, we have reported that 9% of treated aneurysm needed the treatment for recurrence in chronic stage. So it has been believed the aneurysm developed based on the medial defect, like as seen in this pathology, and this internal elastic lamina is lost at the origin of the PCOM artery. During surgery, we sometimes come across this kind of the linear pathology within the vessels, which might be an initial change of aneurysm formation. Actually, I don't know. It is really means a medial defect. You can see another example. Here you see the next to the aneurysm, you can see the very linear pathology here, and this small thing is maybe the origin of hydrocerebral aneurysm. You have been this kind of the pathology not only at the middle cerebral artery, but also at the internal carotid artery, like this and like this, and then develops the aneurysm. So I think the aneurysm, from this observation, I thought that aneurysms develops from the cleft in shape of linear curved line, not from the hole shaped cleft. So on the other hand, creeping of aneurysm is to obliterate three-dimensional shaped aneurysm orifice into two-dimensional shaped curved straight line with the blade of aneurysm creeps. So it is very rational that aneurysm originates from a pathology of curved cleft line, curved or straight line in shape, and creeping is to restore the shape of the artery into the original form. I think this is one of the reasons the neck creeping has been a robust neurosurgical technique during almost a half century. So next, most of aneurysm, that around 3/4 of MC aneurysm, in my experience, develops from the cleft in shape of linear curved line as a bifurcation. I defined this type of aneurysm as a bifurcation type. On the other hand, around 20% aneurysms develops from the aerial medial defect appeared on the branch of the artery. This variation was named as trunk type. So, as mentioned before, ideal creeping is restoring vascular structure into the original shape. So here I define the closure line as curved or straight line on the aneurysm emerging at creeping, no matter how you apply the creep to the aneurysm. If you creep like this, closure line appears here, and if you creep like this, closure line appears here. But here it is reasonable to think that cerebral aneurysm has its own ideal closure line, which corresponds to the shape of initial pathological change. This is a closure line concept. So therefore, in the bifurcation type aneurysm, closure line should emerge perpendicular to the M2 branch, perpendicular to M2 branch. In this MC aneurysm example, you can see the creeping parallel to the M2 leaves the thin aneurysm wall under the creep, while perpendicular creeping to M2 makes almost all the aneurysm wall to disappear. This is a non-ruptured MC aneurysm. Now you can see the closure line here, and then I apply to the clip to form the ideal closure line, forming a curved line using two clips. View from the left side and also the right side. You can see the angle formed by M2 branches become narrow into maybe the original angle. I recommend you to freeze the aneurysm and branches as far as possible to avoid kinking of these arteries. So let me complain here a little bit. You know that many aneurysms have three-dimensional shaped orifice. So single straight clip is not enough to close. But when I proposed the combination clip techniques and the concept of closure line in 2007, all the famous neurosurgeons have told me that your idea is just bullshit. What you might better to do is reforming the shape of aneurysm neck by coagulation prior to neck clipping. Okay, forget about my complaint. These are the examples to use the combination clips to form a curved linear line. You can clip with trunk clips, and you can combine multiple clips. This is a large MCR aneurysm in which MCA branches seem to originate from the aneurysm, and the ideal closure line looks totally gone. And there's a completely obliteration of the blood flow and debulking the aneurysm. And you have to clip and remove and clip and remove. I have to try and try again and again. But finally, I can close aneurysm with using the fenestrate grip and preserving the M2 branches like this. And now, finally, I can successfully make the closure line like this, with preserving the all artery branches. So post-rupture 3D CTA, you can see the no residual aneurysm as well as preserving the branches of the MCA. On the other hand, in trunk-type aneurysm, closure lines should emerge that parallel to the M2 branches, restoring vascular diameters. So you can see this aneurysm is trunk-type. Here the aneurysm originates from not branch on the, but not on the all of the branches. So the parallel clip did work very well on this type of aneurysm. This is another case. You can make a good closure line with a combination of two clips. So there is a combined type aneurysm in which the initial change involves the bifurcation and also the branch wall. Less than 10% of aneurysm was found to be the combined type. So this aneurysm seems to be the combined type. So we dissect aneurysm and neighboring arteries freely from the surrounding structure as far as necessary. Temporary creep for M1 is very helpful to reduce the bulk of the aneurysm, to ease the handling of the aneurysm by creeps and help of the suction irrigation, and to place a creep in an appropriate position. So there is still left the thin aneurysm wall here and also here. So I added two creeps here and also this spout. To make the good closure line and to eliminate the abnormal vascular wall. Post-operative CTA looks good. And in summary, neck clipping with ideal closure line may provide you secure and less possibility for aneurysm recurrence because of chance of residual become less. It may be also safer for parent artery preserves preserve it maintains anatomical relationship. But neck clipping with ideal closure line is not always possible to perform. One of the main reasons is that clip application is restricted by approach corridor. In that situation, mobilization aneurysm makes the closure line adjust to the approach corridor used for clip insertion. This is a trunk type aneurysm. Perpendicular clipping seems to be cause the kinking of the branches. In this period, if you put the clip here, it might cause the kinking to the aneurysm. So therefore, I mobilize the aneurysm completely like this and place the clip parallel to the M2. So after some manipulation, I can clip the aneurysm without the kinking of the arteries, branches. This is another case. Special clip applier was used to adjust direction of the clip blade to the ideal closure line. In this case, the only one single clip is enough to adjust the closure line and eliminates the normal vascular wall. So the other reason is the sclerotic change appeared on the aneurysm wall and the neighboring arteries. So you can see the retrosclerosis here. So I give up to the perpendicular clipping. So I just insert clip parallel to the M2 branches. After some replacing the artery, the clips, finally closure line was made. Like this. So I realized that this concept works very well on the MCI aneurysm. Another question, whether we can apply this concept to the aneurysm of another locations. So my answer is it's yes in almost all cases. This is an ACOM aneurysm through the interhemispherical approach. Interhemispherical approach is Dr. Nataro is an expert. But in this approach, using this approach, it's ACOM aneurysm is very similar to MCI aneurysm. So you can make the combination clip technique through this approach and make the closure line and eliminate the abnormal vessel wall as far as possible. So this can be used for the large ACOM aneurysm through interhemispherical approach. So the post-operative video shows a good operative CTA. So I think can be used for the ICPC aneurysm. But in this limited time, it's almost midnight in some countries. So I don't show the video, but it is applicable for the ICPC aneurysm. So in any location of aneurysm, wider surgical corridor is recommended for clipping with ideal closure line. So in conclusion, I'd like to emphasize that the concept of closure line is really helpful to perform a clip not only perform grip, as well as teach gripping techniques for middle cerebral artery to young neurosurgeon. Multiple grip combination technique for creating ideal closure line is often necessary to achieve complete obliteration of aneurysm. Finally, closure line concept is also applicable at least to the ACOM and ICPC aneurysm. Thank you very much for your kind attentions.
Thank you very much, Dr. Ishikawa, for your technique. I have to say that I saw this technique maybe 11 years ago. And since I returned to Mexico from Japan, I start to use this technique, and I can assure that this is very effective for aneurysm, complex aneurysms of the middle cerebral artery. Until now, we have reached maybe 200 cases with this technique in our institution. So I would like to open the questions to the audience, to Dr. Ishikawa about his technique. There is one question at first from the audience. Dr. Aldo Hernandez Valencia is a neurosurgeon, vascular neurosurgeon, and endovascular neurosurgeon also. And he asked you, what do you recommend for blister-like aneurysms on MCA bifurcation?
Oh, forget about the closure line for the blister-like aneurysm. Blister-like aneurysm is maybe you have to creep. You have to creep as depends on the situation of the aneurysm. And it's you have to do neck creeping. You have to obliterate the breathing point in any way. Creep and suturing, no matter how you did, it's an important thing is to stop the breathing from the aneurysm. This is this can be an answer.
Yeah, of course. There is another question. Do you have to use adenosine sometime during the section of aneurysms?
I have it by experience.
Okay.
Just a temporary creep. I think the temporary creep is enough and sufficient for the aneurysm surgery.
Okay, there is another question from the panelists. Please go ahead if somebody have some question or comment. Dr. Longo from Guatemala, he's a vascular neurosurgeon. He was with us at the Institute. With your experience, are you using the closure line technique in MCA aneurysms?
I don't catch you.
No. I'm asking some of the panelists.
Mm-hmm. Yeah, always that I have a complex MCA aneurysm, I try to do this technique. I remember to have learned with you the cross line technique. Use multiple clip instead of remodeling the aneurysm done. So it's very effective.
Yeah, I think sometimes it's effective in a complex aneurysm, but in some cases we have to forget about this cross line concept and just cross, and no matter how you did it will be all right. And maybe the bypass surgery with the reconstruction of the artery will be helpful to achieve the hemostasis and reconstruction.
I want to ask you something. In the case of all aneurysms, how do you assure the patency of the secondary branches? I mean, do you use ICG, intraoperative angiography, transcranial Doppler, the intracranial Doppler, excuse me. What do you use to confirm the patency of the M2 arteries, for example, in case of thick wall aneurysms?
Now it's ICG is very helpful, but ICG doesn't give us a very good visualization when it has a sclerosis. So maybe the combination of the Doppler and the ICG, and also the check is multi-potential will assure the patency of the branches.
Okay, thank you. Dr. Arturo Ayala, do you want to make, you have also a lot of experience, do you want to make some comments about this technique of clipping?
Thank you so much, Professor Natal, and thanks so much to Professor Ishikawa. I have one question. After all these years about your experience, what is your opinion about the technique to use the bipolar to modify the wide neck aneurysm?
Wide neck aneurysm. I didn't follow you very well. Can you repeat the question again?
Yes. What is your opinion about to modify the neck of the aneurysm with bipolar?
Oh, bipolar. Bipolar gives a heat injury to the vessel wall. So I think it's I recommend you don't do that. But it's a historical way of technique. So I don't know, but this is good or not. But it will cause a heat injury, I think. So I didn't do that.
Thank you so much, Dr. Ishikawa.
Facebook friend.
Ravin, you want to make some comments?
Thank you so much for your master class presentation. I think that this technique is the key for complete and successful clipping. We are separated by a great distance, just 2,039 kilometers, but the influence of your country in our country is too great and very important. Thank you so much for your time. And thank you for sharing your experience and knowledge with us. I have two questions, Professor Ishikawa. Do you use a special clip for atheromatosus or calcificate aneurysm? And the second question is, I remember your article publishes in 2014 about three-dimensional model for complex aneurysms. Do you have any models for bypass training?
Please let me start the last question. I have a very thin vascular substitute, so this is a very good one. The touch and is very similar to the real artery. So this is, I think, the polyvinyl alcohol or something like that, and this is available, commercially available. So if you want to get it, please tell me. So I will introduce to you the company. Okay?
Okay, thank you.
Okay. And the first question is, I think the strategy for the calcified and atherosclerotic aneurysm. What I think is important is to, in these cases, that the stage clip rate not to close to the arterial branches and keep the distance from the artery to the dome. So that maybe the inside of the vasculature is different from the outside appearance. So just checking with ICG, the cranial Doppler, and you have to very patient, you have to very, I forget that. You have to be very careful for the preserve the blood flow inside. Just don't keep the distance from the neck. That is my advice. Anyway, thank you very much for your question.
Thank you, Professor.
There is another question from the audience. Dr. Ernesto Ledesma from Guadalajara is an endovascular neurosurgeon. And he asked you if you sometimes use the intraoperative angiography, or do you use a hybrid operating room for treating these complex aneurysms?
Yes, I have the experience using the hybrid operating theater. But hybrid operating theater, we cannot get a good situation for the surgery itself. So I have a few experience, but I just gave up to the regular operating theater. But I have the experience, and it is very helpful. But changing the surgery into the angiography, it takes time, and changing the drapes, it's really made me crazy.
Okay.
But I think it will be standard.
Okay. Well, we have now 2 hours from the beginning. I will ask Dr. Bacanelli to have some final comment or remarks about the surgery. Dr. Bacanelli is an Argentinian neurosurgeon, so please go ahead.
Okay, well, thank you so much. I think the conference has been grateful, incredible. Also is very important in the last conference, the closure line, not only to get a very well closed aneurysm, that I think is very important, because we are moving to a preventive surgery. We are facing each day more incidental aneurysm. So I think it's very important that microsurgery have the level of closure that endovascular still haven't reached. The closure line, I think, is a very important concept, not only to well clip the aneurysm, but also to preserve the flow in the bifurcation, because if you follow the way in the aneurysm has grown, you can reconstruct the vessel very well. And I think what is really wonderful is the application of anatomy. Also, as always in the Japanese school, the using of the microsurgical technique and the anatomy, the dissection, how we can see in microvascular dissection for trigeminal neuralgia, also in the other kind of bypass. I think very incredible school, Japanese school, really.
Okay, well, it's now 10 o'clock p.m. in Mexico. It's 12 o'clock in Japan. Mm-hmm. So I want to congratulate for your very kind presentations, very wonderful presentation, and we expect to see you in person in Mexico in the near future. So thank you very much.
You are very welcome.
Thank you very much for the speakers. Thank you very much for the panelists. And thank you very much for the audience that attended this meeting. Thank you very much. Bye.
Bye-bye. Thank you very much, Dr. Natar.
Well,
I really enjoyed the time and the conversation.
Okay.
And the comments are very helpful for me.
Yeah. Okay. Yeah, it's really is a great technique. Eh? I asked Oscar to ask you if we can join because I have about 200 aneurysms.
Okay. Yeah. Yeah.
Okay. So we will be in touch after. Okay.
Okay. Okay. Thank you very much. See you next time.
Bye.
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 Wow.